Welcome to AETCM, the Emergency Medicine channel. So, shall we start? 70-year-old male patient came to ER with alleged history of RTA, that's a bike vs car. On initial 10-second assessment, patient was conscious and oriented. Coming to primary survey, airway it was patent, there is no pooling of secretions. C-spine we stabilized with inline stabilization and secured with Philadelphia collar. On coming to breathing part, respiratory rate is 18 per minute and saturation was 99% in room air. Coming to inspection, there is bilateral equal chest movements and there is contusion present on the lower part of the left side of chest. And there is no any engorged veins, neck veins. Coming to palpation, tenderness present and on the left side lower chest, and there is no any subcutaneous emphysema.
What does subcutaneous emphysema show?
Like on palpation,
you will feel crepitus, true, but what does it mean?
Like we felt like any rib fracture, suspecting rib fracture. And there is pneumothorax.
Air in subcutaneous space, so air should be from lungs. So you should suspect pneumothorax in such patients.
Auscultation part, bilateral equal air entry. So coming to circulation, BP was 150/90, heart rate is 90 per minute, and all peripheral pulse equally felt and CRT is less than 2 seconds. Coming to disability, GCS was E4, V5, M6, and pupils is bilaterally equally reactive to light. Coming to deformity, patient was not able to move the right knee. Range of movement is restricted with tenderness present and swelling was present on the lateral part of the tibial condyle. There is no foot drop or there is no any neurovascular deficit.
In exposure and environmental factors, disability. In disability, your main assessment in primary survey disability is spinal injury, not local injury. Okay, so your idea of disability should be suspecting spinal cord trauma, okay, or suspecting intracranial injuries that can cause hemiparesis or hemiplegia kind of symptoms. Okay, so I'm not saying that you should not mention this. You can mention that patient is having difficulty in moving left lower, right lower limb area, that you can mention, but neurovascular deficit and all we are not going to evaluate at primary survey. That is a local condition. The local condition evaluation is coming in secondary survey. Okay, primary survey is only for life-threatening condition. Okay, so when you are saying this, there can be contusion there, fractures there, ligamental injury there, but evaluating that in primary survey means that it should be life-threatening. It is not life-threatening, you know.
Large fractures like both bone fractures, we can.
Large fractures like both bone fractures?
Like bilateral femur fracture, tibial shaft fractures are life-threatening injuries of extremities. So
how?
Hemorrhage, open fractures.
What is your circulation finding?
Circulation finding was 150.
So if you had hypotension without any open bleeding points, then you should look for long bone fractures, closed long bone fractures causing hemorrhage as a cause of hemorrhagic shock, because your femur fracture can lead up to 3 liter blood loss into the thigh compartment, and tibial fibular fractures can lead up to 1 liter of blood loss over there. So large bone fractures are important to look at circulation, not in deformity. Okay, that's what you have to know, what you are looking for. Life-threatening long bone fractures is only coming when you are dealing with hemorrhagic shock. So the idea is to identify hemorrhagic areas which cannot be seen with naked eye. Okay, if bleeding point is there, you know there is where blood is going. No? So if a closed femur fracture is there, how will you know? So you have to suspect. That is when long bone fractures comes up. Okay. Okay.
Exposure bar temperature was normal, GRBS is 160.
So this patient, first of all, when you told the 10-second assessment, no, you told it's a motor vehicle accident case versus car versus bike.
This car.
Now, in every trauma, our primary survey examination, we should be looking for, not only primary, secondary survey examination also, we should be looking for the impact of injury or impact of the force that has caused it. Is it a low velocity injury, high velocity injury, dangerous mechanism involvement? Okay. So I know 10-second assessment, we do not go very deep into the history, so you may be getting that history in ample part. That is fine. But when you tell bike versus car, it is better to tell whether it's a bike passenger with a motor vehicle accident or a car passenger. But you can easily say bike rider with motor vehicle accident, presence to ER. Okay. So we know bike rider. Okay. Bike pillion rider. So we know it's a person sitting behind higher center of gravity, more chances of getting thrown out of the vehicle, more chances of high velocity injury, more chances of dangerous mechanism. Bike pillion rider has more dangerous injury possibility than a bike rider. Similarly, car driver, okay, car front seat passenger. If you add that one thing instead of car versus bike, you can add car versus bike or heavy vehicles versus and all, but that one addition tells us a huge lot of stuff to anticipate. Now, airway, patient's GCS is 15 out of 50, right? Why did we put Philadelphia collar?
Basically, according to our Canadian C-spine rule, age is more than 65 and patient has a distraction injury also is there, so patient was not able to assess. So we put a...
in that case, when you present the case, you should say there was a distracting injury. Okay, this is where you could have mentioned the tibial fracture first itself. Okay, airway was patent, no added sounds, C-spine non-tender, but patient is having distraction injury of extremity with age more than 65. So C-spine secured with Philadelphia collar. But when you say C-spine secured with Philadelphia collar without tenderness, there is no reason for it. Understood? Okay. Adjoints.
Then patient had a pain score of 10 by 10. We give pain management by paracetamol injection 1 gram IV stat. Then we immobilize the...
You didn't say anything about cannulation.
Circulation part 2 or cannulation.
Should have, no? Sorry, fine.
And immobilize the right knee by splinting. Then we done a USG E-fast.
What splinting will you do to immobilize the right knee?
Ebony splint.
Ebony immobilizer, not splint. We are not splinting, doing a cast splitting. No, immobilizer with above knee support should be given. Okay,
then we done a USG E-fast.
Why did you do USG first?
Patient is complaining of left side chest tenderness.
So what are you suspecting?
Suspecting pneumo, hemothorax.
Anything else?
Nothing. Any...
Other than pneumohemothorax, anything else you are suspecting?
Flail chest.
To do E-fast, what you are suspecting?
Then any injury over the left side spleen.
But that doesn't come in fast, but you should look for splenorenal angle free fluid. Because if splenorenal free fluid is there, splenic laceration should be suspected. Spleen assessment doesn't come in E-fast, so you don't have to mention that. Similarly, pneumothorax doesn't come under E-fast. Hemothorax comes under E-fast, not pneumothorax. So, E-fast for hemothorax versus splenorenal angle free fluid. Okay, then E-fast was negative.
E-fast was negative. Then we plan to take a X-ray, chest X-ray, then X-ray right knee, epilateral.
You take X-ray right knee in primary adjoint. What are the X-rays of primary adjoints?
X-ray, chest X-ray, pelvic X-ray, C-spine.
C-spine X-ray is there?
CT, C-spine is better than X-ray.
in primary adjuvant. After primary adjuvant, you will shift the patient for CT, C-spine.
Chest X-ray and pelvis X-ray.
Only the trauma protocol X-rays are chest X-ray and pelvis X-ray. There is no C-spine X-ray. Okay, you have to really understand what we are dealing with. We are looking for life-threatening condition. So you want a chest X-ray to rule out pneumothorax, lung collapse, flail chest, isn't it? All these can cause life-threatening condition now or maybe a few hours later. Pelvis X-ray to see whether it's a unstable pelvis. Okay, especially when there is a hemorrhagic shock. But C-spine X-rays we don't take in primary survey adjuvant. We can take it afterwards. Okay. So knee X-rays comes in secondary survey adjuvant, not in primary survey. So you should not mix and match. Whatever patient had, I will put in primary survey should not be done. Okay. Then anything else? Any other adjuvants you want? Anyhow, you told in primary survey you are having long bone fracture. Do you want a complete blood analysis point of care or hemoglobin level? You want a baseline hemoglobin to assess maybe in 2 hours or something whether hemoglobin is depleting, right? Yeah, so you can send routine blood, especially a hemogram to check, get a baseline HB panel. Okay, what else?
Coming to secondary survey, 70-year-old male patient had highlighted known case of diabetic and hypertensive, highlighted history of RTA, bike vs car around 4 p.m. and came to our ER.
Patient was?
Bike rider within 2 hours. Patient was on bike, helmeted rider. While taking a U-turn, a car came from back and hit over his right side. Followed by he fell down to the left side with his chest hitting over the road. Followed by patient was not able to move his right knee and complaining of pain over the right knee and left side of chest. Following the incident, patient was not able to get up from the road. Then there is no history of any LOC, vomiting, ENT bleed, headache, seizure, breathing difficulty or abdominal pain.
So in this thing, only one thing I want to add is when you tell patient was not able to get up from the road, you have a very conscious patient. Now you can clearly ask him why he couldn't. Like he couldn't move his legs or whether he couldn't put weight on the leg. Because if he is saying unilateral limb involvement, like my right leg was severely paining and I couldn't stand, it means that patient is having unilateral limb injury rather than a spinal injury. Patient is telling he can't stand up. You have to rule out paraparesis, right? So that part you need to mention there. Okay, whether both legs he was having weakness or whether it was a one-sided problem. Because when we check disability, we are asking the patient to move his toes or move his feet. We don't ask the patient to lift his legs, right? So against gravity, we are not checking. So grade 1, grade 2 powers will be covered. We will see that patient doesn't have significant weakness. Okay.
Coming to head-to-toe examination. On head examination, there is no any external injury. C-spine, there is no any C-spine tenderness. Chest, left side, lower chest tenderness is there. Abdomen was soft, non-tender, and pelvic compression was negative. Local examination, right knee. Attitude of the knees was full extension. In inspection part, there is no external injuries. Swelling was present and contusion was present over the lateral condyle of tibia. There is no any bleeding or abrasions. Coming to palpation, there is local rise of temperature. Tenderness was present on lateral tibial condyle. Coming to movements, range of movements are restricted. Coming to neurovascular examination, there is no any foot drop and distal pulsations and lateral arterial pulsation was present.
There was no foot drop and
vascular section like popliteal artery pulsation, anterotibial and dorsal artery pulsation was present.
How do you check popliteal artery pulsation?
Popliteal was
how do you check?
And below the
how do you check,
back of the knee.
How do you check this? Flex and check. So you flex patient knee. So you check anterior tibial, dorsalis pedis, and you check posterior tibial. Yeah. Okay, so knee is already extended and you have splinted. Okay. Fine. So, what is the other knee findings that you got? Where is the swelling?
Swelling on the lateral condyle part of tibia.
So, knee joint as such is normal.
Knee joint swelling is there. Moreover, tenderness over the lateral condyle. Swelling was over the diffuse swelling over the knee.
But that you have to mention that whether knee joint swelling is there or not, and from where to where the swelling is. Okay, whether it's involving the knee joint space or whether it is on the distal aspect of the knee joint or only involving the lower leg, tibial part. Okay, why?
Suspect femoral condyle and other.
Yeah, one thing you have to suspect is whether a femur condylar fracture, supracondylar fracture is associated. More importantly, even if supracondylar fracture is not associated, if it is a intra-articular fracture, patient's knee joint will be swollen up. So, if you are saying there is no knee joint swelling, it is a lateral aspect of tibial plateau injury with the lateral aspect of the leg having swelling, not in the middle aspect, and knee is spared, you are saying it's not an intra-articular fracture. Fracture can extend intra-articularly, right? So, intra-articular extension is there or not to understand is very important. Why? Prognostication of the patient is very bad, intra-articular injury, right? What else? What is there in the intra-articular space of knee joint?
Ligaments like
Meniscus
and ligaments.
meniscal injury. What else?
Anterior cruciate ligament.
Anterior and lateral cruciate ligaments are there, isn't it? This ligamental injury should also be kept in mind when there is a knee effusion as such. Then what else can be there? There can be overlying patellar fracture, isn't it? You are saying a significant blow. The car came and hit on the right side of the patient, most probably over the lateral knee area. That may be the reason why he told there is a direct injury and I couldn't move the leg. Otherwise, he fell towards the left, right? So there was more probability that the bike fell on his left knee and left knee to get injured. But his right knee is injured, isn't it? So that should be a direct blow from the car, isn't it? So such a direct blow to the leg is a high velocity injury. So we should suspect all three areas: supracondylar fractures, patellar fracture, intra-articular fractures, and tibial and fibular fractures. Okay. So how will you examine the patient? Obviously, this patient is going to be significantly pain, isn't it? You must have given opioid.
Yeah, initially we given paracetamol, then we given opioid.
Okay. So opioid, anyhow you are given opioid. Even then, will you be able to examine the knee joint? What are the knee joint examinations you want to do?
In this patient, we first of all start with inspection.
For inspection, you really don't want patient to move the lead, no? So pain is not very important there. But when you
patient part like joint line tenderness.
Yeah. So will the patient be able to tell you objectively where the pain is?
Patient had more pain over the lateral condyle of tibia.
Okay.
Other areas also patient felt pain.
So what can you do? For example, this patient is having isolated right knee joint injury, right? Knee area injury. Can be tibia, can be femur or knee. It's an isolated injury. There is no other major fractures or organ injuries are there, isn't it? So this patient is now not in an emergency state. Is there? No. Vitals are stable, hemodynamically stable, isolated injury which is non-life-threatening injury, isn't it? So you can examine the patient. You can take time to examine. So what will help you to examine this patient better?
Giving proper analgesics.
Yeah, IV. You have given fentanyl. What you gave?
Fentanyl.
You have given fentanyl. Even then patient is having pain, no? You told more pain towards the lateral aspect, but he is having pain all over. But for assessing joint line tenderness or whether assessing a drawer test is positive or not and all, how can you do? Can you do in this patient or is it not required? Can you do something to improve the patient's pain?
Nerve block.
Yeah, you can do a nerve block. What nerve will you do?
Basically, separate by tibial and common period is a branch of sciatic nerve, so you can give sciatic nerve block.
And a femoral nerve
Femoral
block.
nerve.
Both femoral and sciatic nerve block can be given. Much more easier is what? Because sciatic nerve block, you have to make the patient lie in prone position with a fracture. Much more easier is what? Intra-articular lignocaine injection. You can give intra-articular lignocaine injection. What is good in that? Before infusing lignocaine into intra-articular area, you can aspirate and see what you get. If it is clear, there is no hemorrhagic hemarthrosis. If blood is there, which doesn't mean anything. Hemarthrosis is a very common finding of any knee joint injury, including femur, tibia, or the patella. So, blood in synovial space doesn't mean that patient is in a bad condition and all. It just means there is a injury with bleeding. But what is a major marker when you aspirate? If you get something,
Fat.
yeah, bone marrow contents or lipids, if you see, you can suspect the patient to have,
Fat.
not fat embolism, major injury, including intra-articular extension. Intra-articular extension can be understood with that. Okay, and you can give lignocaine infusion directly into the synovial space. Patient will have significant local pain relief. Okay. Now, what are the main structures over there that you should think about getting injured? Femur, patella.
Femur condyle, patella, tibial condyle, and main ligaments like anterior cruciate ligament, posterior cruciate ligament, meniscal tear, lateral and medial collateral ligaments, then neurovascular structures like popliteal artery.
Okay. So, this patient is saying that he is unable, this patient came in a knee joint injury with the leg in a flexed position, a bit flexed position. Okay. In a flexed position. Patient is unable to extend the knee. What injury will you suspect?
Extension is supplied by femoral nerve, knee extension.
Okay. What injury will you suspect?
Shaft of femur.
Obviously, that's away from our discussion area. No, I'm not asking what and all can happen. What over this area? Knee joint injury.
Tendon, quadriceps tendon injury.
So, popliteal ligament insertion point is in tibia, right? Below the tibial plateau.
Tuberosity.
Yeah, so below the tibial plateau. So, that area, if there is injury, quadriceps femoral tendon will not move and patient's extension will be affected. Then your tibial plateaus are there. Tibial plateaus is what you told as condylar area. Tibial medial condyle and lateral condyle. What most common fractures is?
Lateral condyle.
Lateral condyle, because it is thinner and weaker. Lateral condylar fractures are most commonly associated with fibular fractures. Head of fibula, head of fibula or neck of fibula fractures are usually associated with the lateral condylar fractures. Medial condylar fractures is more common in children. In adults, medial condyle is very strong. So you require significant major trauma, direct major trauma to cause medial condylar fracture. But lateral condylar fracture is much more common. What type of patients will you suspect tibial fractures with the knee joint injury? What type of patients do you suspect tibial fractures? One we told major injury patients, but minor injury patients suspecting tibial fractures, what condition will you suspect?
Old age, osteoporosis.
Osteoporotic old age patients can develop lateral condyle fractures even with the twisting of knee injury. So twisting of knee injury can be cause of that without any major trauma. So that is in elderlies. Okay. What is the diagnosis of choice?
Diagnosis, definitely. CT knee is the
CT knee. Always.
X-ray we can take.
X-ray.
Definitely,
X-ray is the diagnosis
X-ray,
of choice.
basically X-ray, we cannot miss. Chance of missing in X-ray is lateral condyle. If undisplaced, it was not able to. So definitely CT.
Patient's prognostication and fracture severity, you want to assess, CT is the best tool. But for diagnosis, X-ray is the best thing. So X-ray is the primary management if you are having suspicion of tibial fracture. Especially clinical suspicion is very high, X-ray is more than enough. When you are suspicious of clinical suspicion is lower, then only you have to think about CT for a better visuality. So you take normally what X-ray you take?
Epilateral and oblique.
AP lateral you take. Do you take oblique here? Do we take oblique knee X-ray here? No, we don't take, right? Yeah. But as you told, in AP lateral X-rays, if you think your visibility is very poor, you are not able to appreciate the fracture and you are suspecting there is a fracture, then oblique views can be taken to discriminate the fracture particles. And even in that condition, you are not seeing a fracture line or proper displacement, but clinically you are suspecting, you can go for CT. What else? What other investigation can you do? What other imaging can you do which will give you more information?
Other injury, we can take a skyline view to
Rule out patellar fracture.
Then tunnel view,
Okay.
intercondylar fracture.
Okay.
Then we can take MRI to rule out ligamental injury.
So you can take MRI. So if you are really suspecting X-ray, it is better to go for a suspecting fracture. It is better to go for a X-ray. And if your center is advanced enough to go for arthroscopic ligamental repair and all, you can take a MRI to see associated ligamental injury also, which will prognosticate for a orthopedic. From emergency side, it's not going to make any difference. So from your side, X-ray is more than enough. How will you manage this patient?
From emergency side, we will give analgesics and immobilize the joint because immobilization causes decrease the pain relief. Then we will check for any hemodynamic instability.
Immobilization,
Analgesics,
cold compression.
cold compression.
Inflammation should be suppressed, no? So cold compression and elevation from heart level to prevent edema over there. Why prevention of edema collection over there is important? He just now told immobilization, ice pack application, analgesia and intermittent elevation above heart level to reduce edema collection. Why edema collection is, prevention of edema collection is important?
It will cause compartment syndrome.
So you should not miss elevation, right? What are the compartments of lower limb?
Lower limb legs, we can anterior compartment, lateral compartment, and deep compartment. Deep is divided into
How many compartments?
4 compartments.
4 compartments.
Posterior compartment divided into superficial and deep.
Posterior compartment is divided into superficial and deep. What are the most common compartments associated with tibial injury?
Most affected by anterior compartment because of low space.
Okay. What are the most common? Anterior compartment then? Except superficial posterior compartment, all other compartments are affected because all other compartments, base of the compartment is formed by
Musculofacial.
tibia. Tibia is the base. Only the superficial posterior compartment has the fascia as the base. Okay, so any tibial fractures causing significant edema or bleeding into the compartment, any 3 of the compartments can be affected. Anterior, lateral and deep, posterior deep compartment can be affected. How will you suspect compartment syndrome?
Compartment syndrome is suspect by, one is by pain. Pain is was not like patient disproportional pain.
What is disproportionate pain? So what is the normal pain for a tibial plateau fracture patient?
Otherwise is pain on passive stretching.
That is correct.
Pain in persistence.
You can't say disproportionate pain. See, pain sensation of patients are different. So you may think that patient is unnecessarily showing that patient's pain sensitivity can be low. So pain on passive stretch of muscles, that is important. Then
Paresthesia, tingling sensation. Then
what if
tenderness.
patient is having more pain
Tender,
when you touch? You told paresthesia, right, and tingling sensation. What if patient is having more pain when you touch? You are touching the area only, but patient is saying, I am having severe pain. So nerve compression features not only mean decreased sensation or paresthesia, hyperalgesia can also happen. So hyperalgesia, paresthesia, and this thing, decreased sensation, you can expect there. Then
tenderness.
tenderness localized is there. What else? In later conditions.
South pulse, absence of pulse.
Pulselessness. So what pulses will you look for?
In compartment syndrome of tibia, we check for dorsal pedis
and posterior tibial. Okay. How will you diagnose compartment syndrome?
Definitely diagnosed by checking the intracompartmental pressure, which is normally 0 to 8 millimeter mercury. If it is more than 35 millimeter mercury,
how will you check?
That is checked by striker.
You have compartment, intracompartmental pressure device, monitoring devices are there. You can insert into the muscle layer and see the pressure. Do we have it? So how will we diagnose?
We will check the grip of the...
You can serially monitor the limb girth and see whether it is increasing. Easiest way. But what is the problem?
Waiting for...
Time. Correct. Time is the problem. Second thing?
You can check a Doppler, hand Doppler.
Problems we were saying. Observer variation. If place you are checking in one place, another person is checking in another place, there will be variation. So, there, but observer bias will always be there. Better is, you told. What we used to diagnose compartment syndrome?
Doppler, hand Doppler we can check any.
Hand Doppler, what will you check?
Absence of pulse. You can
that time absence of pulse is there. You don't have to check. You know there is compartment syndrome. You want to rule out compartment syndrome. How do we rule out compartment syndrome? You do arterial Doppler. You do arterial Doppler of bilateral lower limbs. Injured leg and check for relative decrease in arterial flow and venous flow of injured limb to the uninjured limb. So your left leg is normal now, no? You check the arterial flow rate in that and check the arterial flow rate of the injured limb. If it is compartment syndrome is there, it will be reduced. That's how you can confirm compartment syndrome without invasive techniques. Okay? Fine. So if compartment syndrome you are suspecting, what will you do?
Fasciotomy.
Emergency fasciotomy should be done. You should not wait for it to worsen. But in case of fracture, they should take for intraoperative fracture management they should take. And fasciotomy will be done simultaneously. Okay. So, we were in management, edema part. Then we came here. What else?
Neurovascular deficits, neurological deficits.
All that is compartment syndrome. We told paresthesia features. What are the 5 P's of compartment syndrome? Since you went there.
Paresthesia, pain.
Tell.
Pulselessness.
Pallor? Purpura? Paresthesia? Pulselessness? Paresthesia? Pallor? Pain? Paralysis. Loss of function, that is paralysis. Okay. All this is done, management part. We were talking about limb elevation to prevent edema. That is how we came. Okay. What other management will you do from emergency viewpoint? Splinting already we have done in secondary survey itself.
if there is any open fracture is there, we can means like we can start on antibiotics and
Obviously, prophylactic antibiotics can be given if there is any superficial injuries over the fracture site. Then it will become an open fracture. Definitely, the orthopedician is going to take for emergency open surgery management. They are going to take. What else? Does this patient require fluid management? This patient requires fluid management. It's a long bone fracture, isn't it? The patient at right now, you are having a BP of 130, 80 or something. That doesn't mean the patient will not go into hypotension. So this patient requires fluid management. It's not bolus management. Continuous fluid management as well as looking for hypotension should be done. Okay, so continuous vitals monitoring, BP monitoring and fluid management should be given. What else? This patient, so let's think about this as a elderly patient with a tibial plateau fracture, maybe 70 years, 75 plus years. Most probably ortho will take for hemiarthroplasty, right? So patient is under you. After 1 or 2 days, patient develops breathing difficulty. What will you suspect?
suspect like long bone fracture, suspect fat embolism.
After 2 days,
First ever hospital cured infection, then
you suspect DVT. 48 hours over, DVT is the first thing. Then you can suspect infection. Fat embolism occurs usually at the time of injury. Okay. More the time goes after the injury, more chances of DVT due to immobilization occurs. Okay. So DVT prophylaxis should be started for immobilized patients with long bone fractures. That is the main thing one want to convey is DVT prophylaxis should be taken. Other than that, analgesic management, we told. That's it, huh? Okay. Anything else to add?
this fracture diagnosed as Schatzker type 2 fracture on CT. CT right knee was taken showing comminuted fracture involving the lateral tibial condyle with minimal displacement. So it comes into the classification of Schatzker type 2.
How will you dispose this patient?
Undisplaced pressure, we can conservative management,
How will you conservatively manage this patient?
like immobilizes the knee with immobilizer, analgesics, pain medication, DVT prophylaxis.
Will you discharge or don't discharge? That is disposition means. So this patient is a comminuted fracture of lateral condyle without displacement. What are you going to do? You only made that point up. What will you do? Require surgery?
This patient done surgery.
This patient requires surgery?
Comminuted fracture,
Undisplaced comminuted fracture of lateral condyle. Require surgery?
undisplaced was
Up to surgeon, but you can manage it as conservative also. How will you manage conservatively? Here we put cast. What is written? You put hinged braces. You put hinged braces. Okay, anyhow, we put cast and send the patient, admit the patient in ortho, right? Plan for surgeries. Okay. Anything else?